Still in the lead. Say what?
Oh, I got it wrong. Me too.
Good job, guys. All right, see who's the winner. It's K, and then TJ, and then F. All right, good job. All right, so let's.
There's 30 milliliters in it.
Let me just make this public in case I don't have to.
No.
All right.
Is 15. 1 tablespoon is 15.
Yeah.
Okay. So 1 teaspoon.
It's 5. You don't even need
And then 1 tablespoon is
Oh,
3.
one cup is 8 ounces. Yeah, 1 cup is 8.
I know. When they ask for ounces, you convert to ounces. When they ask for milliliters, 1 tablespoon. 1 tablespoon is
What's that? We're gonna go do TV. So let's hold what. You guys ready?
Yeah. I have a question for TV.
Yeah.
I was talking to one of the people in your cohort, and she was saying there was a statistic of some sort. She was like 20 or 40 something or other, but she couldn't remember exactly what it was.
I don't remember. But I felt like her questions were fair. Like
Fair.
Yeah, but I don't remember because they normally don't do stats.
But yeah, that's why I was confused.
I have no idea, but I'm just gonna kind of it looks like we are right on track here.
Are we doing tuberculosis?
Yeah, we're gonna do TB first because it's small. That way we can just right through it. And it seems like Jordan, we might have a little bit of different slides. But if I read something that's not the slide, then we're gonna do let's do a side by side. So we have the same here.
Your 40s and 50s are on this one.
40s and 50s, all right. So let's.
She added that.
Okay, so after that, we're on the same major risk factors, primary prevention, pathophysiology, ×2, ×3, signs and symptoms, degree of reaction. We're good to go. I'm scared. All right, so positive TB test, so the PPD. So it means you have TB. It indicates that you have been exposed to TB. It can be caused by other diseases and indicates that you are infectious. Tuberculosis, TB, so infectious disease caused by Mycobacterium tuberculosis. It involves the lungs but can migrate. It kills more people worldwide than any other infectious diseases. 2 billion affected worldwide, 15 million affected in the U.S., and 8 million new cases per year. So none of that is relevant. Like, don't worry about millions and trillions. So tuberculosis, right here. So the late 40s and early 50s, and the introduction of chemotherapeutics, the INH, and the streptomycin. So rises in 1985, 1992, don't worry about years. 1993, trending down, still not worrying. The rest of that I don't think is important. So major risk factors. Do you guys have that slide? Okay. So HIV, it's an epidemic. It's, trying to read my writing here. Many of the HIV patients die of TB or the pneumonia. And it has to do with immigration, the immunosuppressed, the poor and underserved, so like the minorities, homeless, inner city residents, older, the institutionalized, they're all like gathered and grouped in groups or whatever, IV drug users, Native Americans, she has also Alaska Native, and socioeconomically disadvantaged. And then she also added like the healthcare worker.
They're more
So,
at risk.
We're the highest risk.
higher risk. So primary prevention, pathophysiology. So airborne droplets, like through coughing, sneezing, speaking, and singing, which I thought was funny that she added. Rare with brief exposure, so it has to be long-term contact. So pathophysiology, TB. So what happens is it plants in the bronchioles and the alveoli. It's engulfed by phagocytes. I'm pretty sure I'm saying that wrong, but and then she says macrophages and neutrophils, and she refers to them as the scrubbing bubbles. So cellular immune response So my understanding is that they come and they kill they form like constipation, if I'm remembering, like these tubercules or whatever. Can be confined for years, so latent TB. Approximately 90% calcify and heal completely, and 10% become active. So with the latent TB, I have just not doing anything. It can activate anytime, and particularly if immune system is declining. Anybody else have anything that they thought was significant?
So the tubercules are the macrophages and neutrophils that are being clumped together?
That's my understanding of it.
Because that's what I have here too.
Yeah, okay, so.
And then when they heal, I also have that they create cavities within the lung.
Mm-hmm.
I don't know.
So, I know that eventually they eat through the lung, right? Is that what you mean?
Yeah, like they create so many cavities.
Yeah.
That they end up.
I think I do have that coming up. So pathophysiology continues the epithelioid cell granuloma, the fusion of inoculated macrophages, so the clumping. It takes 10 to 20 days, and that's when she was saying when the latent becomes active. The tubercle, I can't say that word, the tuberculo becomes necrotic and it liquefies. So then I says it migrates into the lymph and goes elsewhere in the body. Mm-hmm. It drains into connecting bronchi and causes cavities in the lung itself. And then fibrous calcifications occurs and seen on x-rays. So this is when the latent becomes, the slide becomes active.
So when the tubercle becomes necrotic and liquefies, that's what makes it active?
I think that is when it becomes active. I don't know if that's what makes it active, but that's what's happening when it's active. All right, anybody else have anything important?
Yeah, I have the bad liquid is what makes it active.
So the liquid is what makes it active?
Mm-hmm.
Okay.
And then you can breathe that out on someone and they can get TB.
For the fibrous calcification occurs, I also have that it can be seen as collagen scarring.
Okay. All right, so pathophysiology, TB continued, can spread via the lymphatic system into the bloodstream. Spread usually to upper lobes of the lungs, kidney, bone, cerebral cortex, and adrenal glands. And I feel that spread where it's not only the lungs, I feel like the elsewhere parts are important to know.
Because they're the same. Oh, okay.
Eventually, cellular immunity limits multiplication and spread. So the signs and symptoms, the degree of reaction. So I feel like all these symptoms are going to be important. In fact, I'm thinking I feel like this is screening select all that applies. But degree of reaction, so that weight loss, they lose their appetite. The fever, they're going to have a low-grade fever. They're going to have night sweats. They're going to cough more frequently. They're going to be fatigued, and they're going to have painful breathing. And this hemostasis is like the coughing up blood. And I have that blood in the spit is the first sign of TB. Wasn't there something she was saying that something resembles this? Was this in a lecture to come up? I might be confusing it with.
I have coughing is the biggest
earliest
earliest
sign.
sign.
Well, I have cough and sputum.
Mm-hmm.
Yeah.
You have cough like with the blood in it, like I have.
that.
Okay.
A lot of
Yeah.
sputum.
And then I put the fever is usually low grade.
Mm-hmm.
So
I
it's
have
not
early
gonna.
on you're symptom free.
I
And then the
feel
biggest
Yeah.
sign and symptom is coughing and sputum.
I
Yeah.
feel like you might start having night sweats and think it's menopause. So that
But
should.
that's not
Oh,
like
yeah.
What lecture were you
That's
at?
not, no, this is the same lecture, but
I'm just kidding.
That's what I've usually found on accident. Like if I
Yeah.
discovered
Something
something.
else.
They don't know it's there.
I feel like there maybe it's another lecture that you have to get tested for something else, so maybe it was you get something else and then they test you for TB first. Maybe it was lung cancer. Is that what it was?
I think
Lung cancer, they'll test you for TB first.
Oh,
They
yes.
test you
Yeah.
out.
To rule it
Yeah.
out.
Yeah.
Pneumonia, that's what I was saying, it's pneumonia.
Maybe. All right, so TB test. Oh, did I skip something? All right, yeah, I did. So diagnosis, so medical history, physical examination, this PPD test, and just you be aware that you can get a false negative. And then you have this quantiferon TB test, which is a blood test, chest x-ray, diagnostic microbiology, and I have AFB culture, the acid-fast bacillus is the final confirming, and I have that highlighted, so it must be uber important.
Which
The-
one?
The
final
AFB
confirmation.
culture.
This is
final
the confirmation.
She said that was a diagnostic
final.
microbiology.
Mhm. That last one, the AFB culture.
Final test to confirm, yeah.
It's
And then
the-
And that has to do with the sputum, right?
Which one is the most important?
Yeah.
This one, the AFB. The acid-fast bacillus culture. All right, so
Can I add?
yeah, always add.
She also said the biggest thing we want to diagnose will be the PPD test.
Yeah, I have that starred and underlined.
Say that again.
The Mantox tuberculin
Mhm.
test. That was like another big one that she's.
yeah.
Yeah.
I have, if inconclusive, they will do the next one.
Mhm.
This is the one.
Yeah.
All right, so this TB test, so it's a purified protein derivative, and it's an intradermal injection. It's done in the forearm. Am I on the same track as you guys?
Yes.
I guess I added my own bullet there, sorry. Induration occurs, so you're going to have that hard bleb, and we're going to read it in 48 to 72 hours. So it's invalid before or after that. A positive result would be greater than or equal to 10 millimeters. So I'm trying to read, like, I don't know if she said measure the wheel and the red around the bleb, and I think I found that to be wrong according to the book.
She said when you measure the wheel.
Yeah.
Yeah, it's already.
Okay, so because we like kind of threw an uproar before we even like saw this on the, it wasn't even on the test, but she was saying measure the red, and I was like, no, you know, but then I was too scared to say anything to Jordan because she's Jordan. False negatives, immunocompromised, so they're going to be positive if they're greater than or equal than 5 millimeters, and it does not differentiate between active versus latent TB. So I do have, like, you can get a positive reading 2 to 12 weeks after inoculation, and it does not diagnose, it just shows exposure. So a lot of people, like a girl in my class, she did some mission work in China, and she just was exposed to it, so she's always going to come up with that positive test.
When I was 6 years old in my country, I had the BCG.
Mm-hmm.
So every time I had my skin, I don't have the induration, but it gets really red.
Yeah,
So now I just go and get them.
so you have to get the x-ray. And where are you from? Where are you from?
Uruguay.
I can't even say that.
Uruguay.
I have
Uruguay.
two
It doesn't
like-
come positive, but it's just.
Yeah, and then I know
Could be
somebody,
not red blood.
another girl in my class is from Haiti. The same thing. She had the vaccine, and she has to get the chest X-ray.
Okay, then what is the most important in TB test?
What is the most important? What?
In TB test?
I think it's this confirming one, the AFP.
Oh, okay.
Yeah.
It's the best one.
Yeah.
I don't know.
All right.
So-
So,
Copy my-
Just a question real quick. What were you saying about the 2 to 12 weeks?
So I say you will get a positive reading after 2 to 12 weeks of inoculation. So you get somebody with TB, spreads it to you, and then 2 to 12 weeks later, you're going to start getting that.
I have
Yeah.
2 to 6.
I have 2 to
6?
12.
I have
12.
Before
She said
symptoms start.
I have 2 to 12
Time
weeks
of
for
exposure
infection to
will
show
take-
signs and symptoms.
Yeah.
And this is why, like, because even sometimes my notes, like, I'll read something, they're like, I have that, I'm like, and then all the class will say, I'm like, oh, so I'm wrong. So that's why it's good to have, like, the pooling of the information.
Which means you're.
All right, so let's, so chest x-ray, we're going to see a multinodular lymph node, cavitation in the upper lobes, and calcifications of old lung lesions. So I do have, like, she must have brought it up again, the acid fast is the diagnosing. So I don't know, she just, like, I rewrote
Yeah, I
it.
have like not final confirmation for chest X-ray.
So it's that acid fast. So definitely she's saying it more than twice. So definitely test-worthy question, right?
Actually 3 times on the next one.
Awesome. See, we already got a question on the test, right? So 3 diagnostic microbiology. We're on the same track. So 3 consecutive sputum samples, 3 different days. You want that first cough in the morning, and a bronchoscope may be needed. We're going to have gastric washings for children due to they swallow their mucus. CSF to see if it, the cerebrospinal fluid, to see if it's spread. So if it's suspected that it's extrapulmonary, it may take 6 to 8 weeks. So I have it grows slow. And I have something on the nucleic acid amplification exposure. Does anybody have that? Like that's just tagged like floating.
What?
The NAA. That might be later.
Yeah, she said it. I wrote down nucleic acid something.
Yeah, and I think that if it's not anywhere
It's
on
much more
her,
rapid
I don't see it
diagnosis.
anywhere else. So she's usually not like, she's not that way where she will just test, but I have no idea what that
I
is.
emailed her asking her for clarification on her pneumonia lecture, and she was like, if I said it in class, it's fair game. I don't know.
That's to cover their butt.
Yeah.
But she's pretty spot on. All right, so this drug therapy. So active TB is treated with up to 4 drugs, and I'm not going to really try and say these words. So that INH, the Rifadan, the Myobutal, and the next 2. And so treatment of 6 to 12 months, multi-drug therapy, and decreases the chance for drug-resistant strains. So I know some people get really upset when they read like the trade names and not the generic names, but that's the reason why, because nobody can say the generic names. So anyways, so basically here's where like patient teaching is critical, because we want to make sure that they're taking their medications for 12 months. So it's very critical that we have that the 12 months is the gold standard that we tell them to take to be compliant. So drug therapy, so patients on antiretroviral drugs for HIV cannot take Rifapen, Rifapen and pyrazinamide for 2 months, sputum cultures monitored, and then weekly, then progress to monthly. HIV patients treated with additional 6 months. Active TB is placed in a negative flow room, so the door is shut, the air is pumped into the room, and exhaled air will be sent outside, and the UV will kill it. And usually 2 to 3 weeks are 3 negative AFB smears. So she was saying, so these people are going to be in a room for 2 to 3 weeks until they have 3 negative AFBs. So she was just going to say, like, you really got to make sure that you're on top of your patient's social, like the psychological aspect, because they are basically isolated.
And I want to make sure I got it right. The second bullet about the whatever those 2. So everyone who doesn't have HIV will be on those 2 meds for at least 2 months.
Yes.
Okay.
Except for a patient with HIV.
I thought she said that was for everyone.
No, because the line
HIV
above
can't have
it,
it.
you can't, the people with
It's
HIV.
for, yeah, I have everybody too, but it's everyone minus HIV patients.
Okay.
Yeah.
For the drug therapy, when it says up to 4 drugs, does that mean that they'll be taking at least 4 of those 5
They
at a
could be
time?
taking up to 4 at the same time.
And then where it says like multi-drug therapy back on the previous slide, what does it mean when it says like decreases chance for drug resistant strains?
So with the TB, there's not just one strain. So they're just giving you like, I don't want to say broad spectrum antibiotics. I don't know for sure, but they're just trying to cover all the bases.
It says the combo of all
Yeah.
the 4 drugs.
So they're just trying to like
Bugs
kill it
aren't
all.
getting used to it.
Okay.
Yeah. All right, so non-compliance. So this is a major factor in the emergence of drug-resistant strains. So that's why they have it. They're taking the multi-drugs. So they have this direct observation therapy. So this is, I feel like, let me see what this was saying. So if the patient can't afford the medication or they're non-compliant, they will have to go to the health department daily to take the pill. So I'm not sure, I might be like screwing up my memory of this, but were they saying like the police get involved?
Yes.
Yeah.
Okay, so this was, okay,
Arrested.
yeah. All right, so follow up for 12 months after completing therapy and liver function tests monitored throughout the therapy. These drugs are hepatotoxic. All right, how are we doing? We're good?
That's something to
Yes,
add.
always.
She's saying that the biggest problem was the non-compliance,
Mhm.
and that's the reason why we can't eradicate TB, because people don't take their medication for the whole course, and then that just creates more resistant TB. I thought that was pretty important.
I feel like it's like the
Non-compliance.
non-compliance. I think that dot is kind of important. Like, I don't know if, well, maybe. I won't finish that sentence. All right, so latent TB treatment. So INH given once a day or twice a week for 6 to 9 months. 9 months greater effectiveness, and then the vaccine. So is this the vaccine here? So the Bacille, Calmate, or the BCG. And then she was saying that the efficiency of this vaccine is unclear. So anyways, nursing diagnosis, ineffective breathing patterns, imbalanced nutrition, less than body requirements, non-compliance related to lack of knowledge of disease processes, lack of motivation, and long-term nature of treatment. So basically it's expensive. Ineffective health maintenance and accumulation
If someone has TB, then they'll take up to the 4 drugs, but if it's latent, they're only going to take INH.
It appears that's what she's saying. So there's INH. Notice that the time is like 9 months, where the active is like 12 months. And I think I also have if they're immune compromised, it will actually for the latent.
Because their body can't suppress it.
Right. Oh, that makes sense. That makes sense. They're immune compromised, but if they're activated. So even if they're taking all the meds, all right, so nursing diagnosis, so an effective breathing pattern, imbalanced nutrition, body requirements, non-compliance related to lack of knowledge of the disease process, lack of motivation, and long-term nature of treatment. Good, Hillary? Yeah. So just pay attention to these nursing diagnoses, because I do at least see one every test, like, and it's usually like ones that you wouldn't expect, like disturbed body, like I'm not saying for this one, but like something that is just kind of outside the box a little bit. So anyways, nursing, so screening of high risk populations, identification of contacts because they need to be tested, assess for exposure, respiratory isolation, and I feel like this was important. So the negative flow room, the ultraviolet lighting, the high efficiency particulate mass, I feel like that's going to be really important. So you want to make sure it has a tight fit. So they do like a noxious smell test to make sure that it fits properly. And so these actually like filter out that droplet nuclei. And what else?
I have also that if there's TB, it needs to be reported to the health department and
Yes.
the CDC.
I have that exact line. Anybody else have anything?
TB is sensitive to ultraviolet
Yes.
light.
So I have that they usually will turn on the ultraviolet light while they're sleeping.
It kills the bacillus.
And she says
So the UV kills the bacteria that's laying on all the surfaces. And then tertiary prevention, so patient education. So we're trying to eradicate, like I'm just adding my own bullet here. We're trying to eradicate, so we want to make sure they're teaching to cover mouth and nose, hand washing always, right? Medication compliance, so teaching or DOT. Notify health department and 5% of our patients will relapse. And then she kind of was talking about some TB thing, something, I don't know, that wasn't important.
She was doing this whole thing about like that there's a social stigma to TB.
Mhm.
It's like that TB is silent
Yeah.
and stuff, so I don't know if that might be related to.
That won't be on the test, but
I have know the signs and symptoms and get help early to prevent
Yeah.
relapse.
You want to teach the signs and symptoms.
Yeah, that's
so
The early testing.
we
the
did
last
that.
one there.
So what
High
I'm going to do
efficiency.
is just, do you guys want to stop and do your questions, or do you guys want to move on to pneumonia? Should we take a potty break? Everybody got to use bathroom? Everybody good? Everybody want to do a jog around the parking lot? No? All right. So we'll just get right on to pneumonia, and then so yeah, looks like we're on the same thing here. So anyways, did you guys have pneumonia already? You guys finished all your content, right? So infection, the invasion of body tissue by microorganisms with the potential to cause a disease. So this would be foreign substances, infectious agents, diseases, abnormal cells like cancers, and drug-resistant organisms like TB. Organisms causing infection. So bacteria is the most common. It's transported by air, water, food, soil, body tissues, and the fluid and inanimate objects. So I have here that TB can live up to 30 days. Viruses, they must enter living cells to reproduce. Families include rhinovirus, hepatitis, herpes, and HIV.
I have flu written there too.
And what?
Flu.
I put viruses have to be in the cell to propagate.
Mm-hmm. All right. So organisms causing infection. So you have your fungi, which are yeast and molds, and then I have especially in the intestinal tract.
Yeah.
Is considered normal flora in the body, so the Candida albicans. And remember that this is our opportunist infections, right? So parasites, they live on other organisms like protozoa, helminths, arthropods. Types of infections, so local infections limited to a specific part of the body. Systemic infection, so microorganism spreads and damages different parts of the body. And bacteremia is blood invaded by bacteria, and it can lead to septicemia. So types of infections, acute infections appear suddenly, last a short time. Chronic infections, they develop slowly over a long period of time, and they persist for months or years. I don't really have anything for that. I don't know if you guys just touched on it.
Then it can occur for a lifetime.
Can occur for a lifetime. Okay. So respiratory disorders. So do you guys have this little question here?
Yeah.
The type 2 epithelial cells in the lungs are responsible for storing and excreting surfactant. True or false?
True.
All right. So pleural space. So the problems that are associated with this is the pneumothorax, which is air in the lungs, and then the hemothorax, which is blood, pleural effusion, and emphysema, which is pus, right?
Okay, what is pneumothorax?
The pneumothorax is like, let me read where it says. So it has to do with like the negative pressure. Like if there's going to be air. Let me see. I'm going to try and read this.
I have hole between lungs and pleural space.
Yeah, so what's happening is that we're supposed to have this negative pressure, and then there's like a hole, like the TV will sometimes eat through, and it will release that negative pressure, and then you'll have like air between the thing. So just think like pneumo means air. So, and then hemo means blood, so you're gonna know that there's gonna be blood in that pleural space. All right, so let me just kind of read my side notes here. So I have pleural space as a negative pressure to work against the atmospheric pressure, and it has to overcome that atmospheric pressure. And then when we're talking about that pleural space, we're talking about the exterior interior membrane. So it's going to be in between like the lung and like chest wall. If I'm saying it wrong, please correct me. And then I also have that it can hold up to a liter. Does anybody have that?
I have 2 liters.
2 liters. But if it has that much, it's going to put pressure on the alveoli, then it won't be able to do that that air exchange.
So 2 liters is that.
Did she?
It can hold up to 2 liters.
Hold up to 2 liters.
But that's not like good.
It's not good.
And then I have gas exchange starts in the terminal bronchus,
Yeah.
and not only in the alveoli. So I feel like that was pretty important to know. And I do have the left branch, like the bronchi is the sharper angle. I don't think that's significant, but I'm just kind of calling it out there.
And she said that people get ventilation and respiration confused all the time. Just make sure that you.
Yeah, so ventilation is just the movement of air, and then what was the other one? Respiration is the exchange, right?
Okay.
And then I also have that it maintains the negative pressure between -4 to -10.
Oh, I do have a -4 in there.
What does that mean?
That's your pressure.
Yeah.
So I don't know how, like, I don't think that's, I've noticed at the test, do you feel like they're superficial?
There's,
So-
yeah.
Like, I feel like they're in depth, but they're so superficial. I don't know, it's hard to
It's not going to
explain.
be like, what is the pressure?
Yeah, you're not going to be like,
The
hit
rate.
the -4 or whatever, yeah. But I feel like the gas exchange question was, like, that is important.
Yeah, I think she said it like 4 or 5 times.
Yeah. All right, so I'm going to move on to alveoli. So you have the type 1 alveolar epithelial cells. And I have that these have a high susceptibility to injury. 90% of the alveolar surface, and they maintain the blood-gas barrier. So I do have, right, again, that she was going into talking about ventilation and the respiration. So respiration is the exchange of gases, and ventilation is the movement of air in and out of the lungs. Type 2 alveolar epithelial cells. I have when type 1 gets injured, type 2 can morph into one. Produce and secrete pulmonary surfactant. So this helps the lung to recoil upon inspiration, so it helps us breathe with ease. And that surfactant is a lipoprotein. It lowers the surface tension, decreases amount of pressure needed to inflate, and decreases alveoli collapse. So once again, I have it increases lung recoil on inspiration. What else do you guys have?
Increases what?
I have type 2 can morph into type 1.
I have it. It increases the lung recoil on inspiration.
I have that it moves from a high to low concentration.
It decreases the amount of pressure for us to breathe in and out. Oh, that's.
Mine will right, yeah.
And we worked
She
it
just doesn't-
inhale. Oops, sorry.
Yeah, go ahead.
Oh, I put we worked to inhale, and there's no work to exhale. I don't know.
All right, so let's
It just says
move.
like babies, like premature babies don't have surfactant.
Or they don't have the gas. They
Yeah,
don't
like the
produce the surfactant yet.
Like is there because it lowers the surface tension, so we breathe easier, and then it increases the recoil.
And then protective mechanisms. So we have air filtration, such as the nose hair that capture the large particles, the cough reflex, like upper the lungs that help us get rid of mucus. Mucus secretions allows movements of stuff, she said. Mucociliary escalator, that works the bacteria back up to the cough reflex. Alveolar macrophages, I have excrete peroxide and cleans the lungs. Bronchoconstriction, I have prevent stuff from coming in. And then the epiglottis closure, so it only technically opens up to let us breathe. Anybody else have? Oh, I have also the upper airways are not sterile, but the lower airways are sterile.
She said with the epiglottis it stays open when eating, but wouldn't it stay closed?
I would say that it closes when we eat.
That's
right?
what I thought.
Yeah,
too,
see, I have only
why would it-
opens when we eat.
Yeah, I was like, why would it stay open?
Yeah.
And we would like
Smoke
choke
us.
on our food.
I have it too.
I think it's
So-
because it closes over the
Like your dental.
Doesn't it close over the trachea?
which is where you get your breathing, right?
Right. So you wouldn't want it open when
Yeah.
you eat, 'cause then,
No, but like
food
it
would go.
opens the esophagus. That's what she was saying.
Maybe that's what she
Because originally, like to breathe, our esophagus it's over the esophagus, and then when we swallow, it closes. Well, it opens to the esophagus and closes.
Maybe.
I don't think that was like an important detail, but I mean it's important detail to know,
Right.
but I don't think it was like.
Right.
And then you always I always study with my laptop, so I'm like, what does she say? And I'll Google. I'm a Googleologist. So did you have your hand up?
Yeah. Back on the pleural space problems, she said the most common postoperative was pleural effusion.
Mm-hmm.
So that may be important.
Absolutely.
What is it?
Pleural effusion, she
Are we
said
getting,
is the most common
Are we coming
postoperative.
into it later?
Okay.
Right, just in case.
Pleural effusion.
It was the second. Oh wait, yeah. It was like two
So
slides
pleural
ago.
effusion only happens in post-op? Is that like?
It's common.
It's common.
She said that's the most common
later.
problem.
Is there one coming? Is it coming later?
Oh, yeah, I have
I
it
know I
before.
wrote it exactly.
I remember seeing something.
That was before. We already
Yeah, I
passed that.
did see. I do see it before, but I'm just checking to see if it's later in life here.
Yeah, it's
So it's
it's
the
slide
most
10.
common.
Slide 10.
Yeah.
It says
Most common after surgery.
pleural space pleural effusion is the most common post-operative.
Yeah, you know, they ask some questions.
I feel like those people, the court people. Read back to the court.
All right. So, anyways, I have a side note, and I don't know what slide she's trying to talk about, but I have something. The stimulant that makes us breathe is our arterial CO2, our hypoxic drive. So I have be careful, our hypoxic drive. If we want to be careful if we wash out too much CO2 on a COPD, they will stop breathing. They have to maintain a increased level of CO2 than our normal 35 to 45.
Yeah. Could you repeat that?
Yes.
So I have our hypoxic. So the thing that makes us breathe is the CO2 levels in our bodies. So that's what drives us. But for the COPD, they need a higher CO2 to maintain that their breathing. And I'm trying to remember. She was saying you don't want to just throw on the dose. Do you remember back to fundamentals where they have the different types of mass, like the Venturi mass, and you can control it? And I remember thinking back then, why don't we just blast those guys with O2, right? Just pump it up. But it's the reason we don't want to get that CO2 out of their blood, because then they're going to lose that drive to breathe, that hypoxic drive.